Thank you for allowing me to give this talk on oropharyngeal carcinoma. The boundaries of the oropharynx are anteriorly, it's formed by the circumvallate papilla and the anterior tonsor pillar, posteriorly by the posterior pharyngeal wall, superiorly by the soft palate, inferiorly by the vallecula, and laterally a combination of the anterior tonsor pillar, the tonsor fossa, and the posterior tonsor pillar. There are four distinct subsites of the oropharynx: the tongue base, the soft palate, the tonsil, and the posterior pharyngeal wall, and we'll discuss each of these separately. The first area is the tongue base. The tongue base is that part of the tongue that's located posteriorly to the chevron-shaped papilla, which are the circumvallate papilla. So everything posterior to the circumvallate papilla is in the tongue base. The schematic illustration demonstrates a lateralized tongue-based carcinoma, but nicely illustrates the junction between the genioglossus geniohyoid muscles and the tongue base. Oftentimes, it can be challenging to identify where the anterior floor mouth, the posterior aspect of the floor mouth ends and the tongue base begins, and this schematic illustration identifies this. When we look at the right-hand side, we can see the genioglossus muscle anteriorly extending posteriorly, and now it transitions into these horizontally shaped tongue base muscle fibers, and that identifies the tongue base. So in the top right-hand corner, we can see this lateralized right tongue-based carcinoma. Now, tongue-based carcinomas do not tend to involve bone, but they tend primarily to extend within the adjacent soft tissues. So one of the most important things that you can do is, first of all, determine whether or not it's lateralized or whether it crosses midline. And secondly, you should try to give some estimate of the size of the tumor, as we'll discuss later for staging. The next part of the oropharynx is the tonsil, and there are three distinct parts of the tonsil. The most anterior part of the tonsil is the anterior tonsor pillar. This anterior tonsor pillar is specifically created by this muscle that runs from the palate to the tongue base, which is a palatoglossus muscle. On this image right here at the bottom left demonstrates a classical appearance of an anterior tonsor pillar carcinoma. We can see that it's extending anteriorly, growing along the superior constrictor muscle, and where the superior constrictor muscle interdigitates with the buccinator muscle is the pterygomandibular raphe, and we can see that tumor is heading in that direction. The middle image identifies a palatine tonsil carcinoma. Now, these carcinomas arise from the middle part, if you will, from the tonsor fossa, and this tonsor tissue, also known as the fascial tonsil, comprises about 90% of all tonsor carcinomas. And on the right-hand side, this is a posterior tonsor pillar carcinoma. These tumors tend to be very rare and arise from this small muscle, which forms the posterior border of the tonsil, which is a palatopharyngeus muscle. Now, when we look at tonsor carcinomas, again, similar to tongue-based carcinomas, these tend to involve primarily the soft tissues. And one of the decisions that has to be made is whether or not these patients will be treated with surgery or they'll be treated with non-surgical organ preservation therapy. So it's always important to identify deep extent. In this particular case, we can see this exophytic cancer that's extending into the oropharyngeal airway, and this patient can easily be treated with transoral robotic surgery. Now, the image on the right is another tonsor carcinoma, but some of the spread patterns that you need to discuss in this is whether or not there's deep extension. We can see this tumor is extending deeply, and partially it faces the parapharyngeal space. It's growing anteriorly along the superior constrictor muscle and towards the pterygomandibular raphe. It's important to convey this information to the surgeon to see this type of spread will be acceptable for them to provide transoral robotic surgery, or whether or not these patients should be treated with some form of non-surgical organ preservation therapy. The next area is the soft palate. And when I think of the soft palate, I always think about the arches, the Roman arch as is seen here, because when we talk about the palate, we talk about the palatal arches. So the soft palate is a palatal arch, and this palatal arch is tethered superiorly to the tongue base by, guess what, two Italian muscles, and those are the tensor and levator veli palatini muscles. So you can imagine that these muscles are tethering this top of the soft palate to the skull base through these very muscles here, which are somewhat formed by these bricks. So anytime that you evaluate the soft palate, you should always evaluate it in the coronal plane. So in the midline, in the middle image shows a nice CT reconstruction of a large soft palate carcinoma. And on the right, this is a contrast enhanced T1 weighted image with fat suppression demonstrating a soft palate carcinoma. On this schematic illustration demonstrates the potential spread patterns of a soft palate carcinoma. The middle image demonstrates this intermediate T1 signal mass involved in the soft palate. This is a typical example of a soft palate carcinoma. And on the right-hand side, we can see this circumferential enhancing mass. Now, because the soft palate does cross midline, when you have these soft palate masses, they can be, if you will, circumferential. And they look, in this case, looks like it's narrowing the airway posteriorly. On the sagittal images, we can see the same patient with a nice reconstruction demonstrating this very bulky soft palate carcinoma. Now, soft palate carcinomas can be pretty well seen on clinical examination, but what's oftentimes hard is to look at that superior extent. It's hard to sometimes get that endoscope around the soft palate to see that superior extent. And this is an example of a soft palate carcinoma that was felt to be limited to the soft palate. However, when we look superiorly, we can see that there's enlargement of the torus tubarius. And when we look at the contrast enhanced T1 weighted image with fat suppression, we can see there's tumor growing along that soft palate. So this was clinically occult. This was another case that had a soft palate carcinoma. And unfortunately, when we look at the skull base, this tumor had grown all the way up and invaded the petrous apex. So notice the replacement of the normal white signal in the petrous apex, the replacement of the normal fat, and compared to the opposite side. And again, this was all clinically occult superior spread of disease, which you always want to try to evaluate for. This is the next area of the oropharynx, which is the posterior pharyngeal wall. And this part of the posterior pharyngeal wall is predominantly formed by the middle constrictor muscle. So this is a schematic illustration of a posterior pharyngeal wall carcinoma, and this is a sagittal reconstruction of a large posterior pharyngeal wall carcinoma. Now, one of the main types of spread patterns we have to look for the posterior pharyngeal wall is whether it extends laterally to involve the lateral pharyngeal wall, but also to determine whether or not these tumors can potentially invade the muscles. Now, CT and MR is not necessarily the best for this. We can give some indication for it. This was an example of a posterior pharyngeal wall carcinoma, and we can see the fat between the posterior pharyngeal wall and the longus colli muscle. Here on the right-hand side, we can see that fat's been obliterated. So in this case, this is suggestive of an involvement of the longus colli muscle. And again, we're not the best at this. The other thing that you can do is also perform axial T2 weighted images. And if you can see edema involving the longus colli muscles, again, that is suggestive of invasion of the longus colli muscles. But again, it's not 100%, but that's another technique that you can use. Now, from a staging standpoint, the AJCC 8th edition has two types of staging for oropharyngeal carcinomas. There's the HPV negative, which was part of the prior staging systems. So this means that if a T1 is based on a tumor less than 2 centimeters, T2 is between 2 and 4 centimeters, and T3 is greater than 4 centimeters. This is exactly the way it was before. And there's also a T4A and T4B. T4A means that a tumor is resectable with deep invasion, but it is resectable, whereas T4 means that it's still resectable, but may not be curable. So T4 deep extension, T4A is resectable and potentially curable, and T4B means probably not curable. So it's important to remember this staging system because this is what was done before, and once we start talking about the HPV positive, there's a new staging system. Now, one clarification that we made in the 8th edition is to this involvement of the medial pterygoid muscle. So in the 7th edition, if you had a tonsillar carcinoma or an oropharyngeal carcinoma that extended into the parapharyngeal space and it abutted the middle aspect of the medial pterygoid muscle, many people would call this T4A disease. But in the 8th edition, this is T2 disease. And specifically now in the 8th edition, in order for this to have true involvement of the medial pterygoid muscle, that pterygoid muscle has to be unequivocally invaded, as is seen here. So abutting is not good enough. It has to invade that medial pterygoid muscle. So this would be T4A disease. And then if this tumor extends all the way laterally to involve the masseter muscle, then this is T4B disease. And clinically that correlates to severe trismus, is how we'd always stage these patients before the wide use of cross-sectional imaging. So in the 8th edition, it identified a new disease, and that is HPV positive oropharyngeal carcinomas. And I think all of us now are familiar with this. So for HPV positive tumors, these primarily involve the tonsil and the base of the tongue, whereas HPV negative tumors can involve all sites. The histology for HPV positive tumors tends to be basiloid, where the HPV negative tends to be more keratinized. HPV positive tumors tend to arise in younger patients, whereas HPV negative tumors are in older patients. The gender predilection is the same. The socioeconomic status tends to be higher in HPV positive tumors and lower in HPV negative tumors. And one of the big risk factors for HPV positives is sexual behavior with multiple sexual partners, whereas HPV negative tends to be more alcohol and tobacco use. Other cofactors for HPV positive include marijuana and immunosuppression, and the incidence of HPV positive cancers is increasing, where fortunately HPV negative tumors are decreasing. One of the good things about the HPV positive tumors is that survival is improved as opposed to HPV negative tumors, which is worse. Now, in order to make the diagnosis of the HPV status, this cannot really be based on imaging. Maybe there are some features that can help us. For instance, cystic lymph nodes in a tonsillar carcinoma are suggestive of an HPV positive carcinoma, but ultimately, the final status has to be determined by P16 immunohistochemistry, where they stain for the P16 protein, or they specifically perform PCR testing for HPV P16. Now, the overexpression, if your lab is doing immunohistochemistry for this P16 protein, there has to be greater than 75% moderate staining. So on the top left-hand corner here, here's a oropharyngeal carcinoma that did not stain. And on the right-hand side, this would be positive staining for HPV because there's greater than 75% moderate staining. Now, in the United States, we all know that the majority of oropharyngeal carcinomas are HPV positive, but realize there's a large geographic variation in HPV positive oropharyngeal cancers. So for instance, in the United States, it's very high, but as we look at other parts of the world, specifically in the Middle East and some parts of India, we can see that the incidence of HPV positive oropharyngeal carcinomas is lower than compared to the United States. Now, it hasn't been fully determined what the cause of this yet. Part of it could be sociological factors, or maybe not as much testing is being performed, but just realize that there is a large geographic variation. Now, when we look at the staging system for the HPV positive oropharyngeal carcinomas, the 8th edition staging system for this reflects the overall better prognosis. Now, T1 to T3 is essentially the same. It's all based on size. But notice for T4, they got rid of the T4A and the T4B. So remember, this represented deep extension, with some tumors being resectable and curable, i.e. T4A, whereas T4B was resectable but probably not curable. Whereas the HPV oropharyngeal carcinomas, these are all lumped into a T4, again, indicating a better overall prognosis. So here's an example. This was a patient that had a tonsillar carcinoma that had extended laterally to involve the medial pterygoid muscle. If this was HPV negative, this would be T4A. Because it's HPV positive, this is just T4. And in this case, on the right-hand side, another tonsillar carcinoma that's extended all the way to involve the masseter muscle. In the 8th edition, this was T4B, but if it's HPV negative, but in this patient, it's HPV positive, it's still T4. So again, a slight improve its staging with HPV positive status. There's also two distinct lymph node staging for oropharyngeal carcinomas based on the HPV status. Now, one of the things that the 8th edition did was clarify the presence of extranodal extension and use this for upstaging. Now, I want to be very clear on this. Extranodal extension
is involvement of the skin, adjacent musculature, neural structures, including the cranial nerve, the brachial plexus, the sympathetic chain, and the phrenic nerve. Now, we can see this on imaging, but the 8th edition specifically says that extranodal extension is a clinical diagnosis, and it's not purely a radiological diagnosis. Radiologic evidence alone may be supportive, but is not sufficient independently. So you have to have clinical evidence. So when we look at the staging system for HPV negative oropharyngeal carcinomas, this is exactly the same as it was before, but the caveat is that when you go from N0 to N3, this all assumed everything was extranodal, no evidence of extranodal extension. But if you have any clinical evidence of extranodal extension, all of a sudden you drop down to N3B disease. So that's why they were very firm about this, because theoretically you can have a lymph node that's less than 3 centimeters that can be upstaged for to N1 to N3B disease. So that's why it had to be very rigid at this point in time to ensure that any presence of extranodal extension has to be clinically confirmed. And it's not just a radiological diagnosis, because that's a very big jump in staging and also has a much poorer prognosis associated with these patients. So in the, we still have N0, N1, N2, N2A, B, C, and N3 disease. But now when you have staging for HPV positive tumors, notice the difference in how the staging is performed. And again, this is reflective of the better prognosis. So N0 still means no lymph node metastases. N1 is a ipsilateral lymph node that's less than 6 centimeters. Now, if it was HPV negative, that first threshold would be 3 centimeters, but because it's HPV positive, it's 6 centimeters, again, overall reflecting the better prognosis. Contralateral or bilateral disease goes up to 6 centimeters again, and that is N2 disease. And N3 disease is any metastases greater than 6 centimeters. So let's take a look at some of these differences between HPV negative and HPV positive. So this was a patient that presents with a 4 centimeter lymph node involved in the left side of the neck. If this was HPV negative, this would be N2A disease. If there was evidence of extranodal extension, this could be upstaged to N3B disease. But this patient was HPV positive, so the nodal staging was N1 disease. So you can see much better, a lower staging will happen, and also a much better prognosis. Now, here's a patient that has multiple metastatic left-sided lymph nodes. If this patient was HPV negative, this would be N2B disease. Or if there was clinical evidence of extranodal extension, this would be N3B disease. But because this patient was HPV positive, this is N1 disease because there's still ipsilateral lymph nodes, all less than 6 centimeters. Again, you can see how that positively affects staging. Now, here's a patient that has bilateral lymph node metastases. They're still less than 6 centimeters. If this was HPV negative, this could be N2 disease. But if there was extracapsular penetration, again, upstage to N3B disease. But because this patient was HPV positive, this was N2 disease. And finally, here's a patient that had metastases of greater than 6 centimeters. If this patient was HPV negative, this would be N3A disease. And if the patient had extranodal extension, then this would be N3B disease. But because this patient was HPV positive, this was all N3 disease. So still pretty bad, but you can see how there's no subclassification between N3A and N3B. So in order to really identify the full impact on imaging and the full effect of HPV status, this was a heat map, if you will, of HPV negative oropharyngeal carcinomas, looking at the T stage and the N stage, and then looking at the various combined stages here, stage 1, stage 2, stage 3, and stage 4. Note that green is the best stage, yellow is okay, orange here is a little worse, pink gets pretty bad, and red is bad. And you can see how it gets worse and worse as you get to the lower right, as you would expect. T4B N3 disease is quite bad. But if you compare that with HPV positive oropharyngeal carcinomas, you can see that if you have T4 disease and N3 disease,
you still have a pretty good prognosis. And you can see a lot more green in here. So essentially, if you still had N2 disease, N2N1 disease, you still had a very good prognosis. And just to sort of, again, to take home that point, if you do have extracapsular penetration clinically, as is seen here on the bottom left, that would still be N3B disease if the patient was HPV negative, but remember, it's still N1 disease if there's no, if that lymph node is less than 6 centimeters. So in summary, what we did over the last 20 minutes is that we reviewed oropharyngeal carcinoma and specifically went over the HPV negative and HPV positive subtypes. We talked about the primary site, the lymph nodes, and staging. Remember, oropharyngeal squamous cell carcinomas require immunohistochemistry or PCR analysis for final clinical staging. And if you are in a private practice or in a frontline area, you may not have this information when those studies come past your desk. So I still think it's important that, especially if you don't have that information initially, is to remember to assess the primary site for local spread. Go ahead and make your measurements because that'll give you an initial staging, at least for T1 to T3 disease. And then also, I still think it's important to measure those lymph nodes for initial assessment. And then once the PCR testing or the immunohistochemistry testing comes back regarding HPV status, then you can put everything together to create that final staging. But I still think it is important to try to measure that primary site and lymph nodes, especially if you are in a community-facing practice. Thank you very much for your attention.